You are on shift in the emergency department or ICU, and a patient's blood pressure monitor alarms 190/115. What's your very first move? The single biggest mistake in acute care is focusing purely on the number instead of asking the real question. Is there active target organ damage? Welcome back to the Next Gen Pharmacist channel. Today, we are breaking down the clinical blueprint for severe hypertension versus hypertensive emergencies. We will cover the crucial triage rules, the underlying vascular pathophysiology, specific organ-based blood pressure targets, and the exact IV pharmacology you need to master on rounds. So, when a patient presents with a systolic blood pressure over 180 or diastolic over 120, they fall into one of two pathways. First, severe asymptomatic hypertension, historically called hypertensive urgency. This is a severe blood pressure elevation without acute target organ damage. These patients generally need oral medication adjustments and ED observation, not aggressive IV drops. And the second scenario is hypertensive emergency. This is severe blood pressure elevation with acute life-threatening target organ injury. This patient requires immediate ICU admission, arterial line placement, and continuous IV infusion. Here is a clinical pearl to remember. The rate of rise matters more than the absolute number. Chronic hypertension might walk around completely fine at 210/120, while a previously normotensive pregnant patient could suffer a full-blown emergency at just 160/100. What actually happens inside the vessel? What is the pathophysiology? Why does a rapid rise in blood pressure trigger organ damage? Normally, blood vessels use autoregulation to keep blood flow steady, but when pressure spikes rapidly, it overcomes this defense. A rapid, severe rise in blood pressure completely overwhelms the endothelium. You get this intense mechanical shear stress that causes injury, which then triggers a massive cascade where platelet and fibrin just deposit right into the vessel wall. We call this fibrinoid necrosis. It narrows the limb, causes severe local tissue ischemia, and then prompts the release of vasoactive substances like angiotensin II and epinephrine. It's wide. It creates this incredible vicious self-perpetuating cycle of systemic vasoconstriction and multi-organ hyperperfusion, just a complete cascade. Now we made a pause here for a second because we are about to hit the most common clinical pitfall. You absolutely must not aggressively lower blood pressure in asymptomatic patients. I mean that if a patient is sitting there at 190/115, but they have got clear lungs, a totally normal neuro exam, and normal labs, dropping the number rapidly with IV push medications is actively dangerous. You see, chronic hypertensive patients have shifted autoregulation curves. Their brains and kidneys actually rely on those higher pressures just to maintain normal blood flow. So if you appropriately tank their pressure, you could literally precipitate an acute stroke or acute kidney injury just from that sudden hypoperfusion. Instead of panicking, clinical guidelines dictate a much calmer, evidence-based 3-step process. Here, step 1, honestly, just let them rest in a quiet room and re-evaluate. Place the patient in a quiet room for 30 minutes. Blood pressure often drops spontaneously. Step 2. Adjust or maybe restart their long-term oral antihypertensive medications. And step 3. Ensure a gradual controlled reduction using those oral agents over the next 24 to 48 hours. Nice and easy. And a crucial point to remember, like a golden clinical pearl, is that immediate release sublingual or oral Nicardipine is strictly contraindicated. It causes unpredictable, abrupt drops in blood pressure that have caused fatal myocardial infarctions and strokes. Now, what if there is acute organ damage? Now you are in a hypertensive emergency. Get the patient to the ICU, place an arterial line, and start titrating IV medications. We have a standard 24-hour protocol timeline. In the first hour, lower mean arterial pressure, or MAP, by no more than 25%. From 2 to 6 hours, if stable, lower blood pressure to roughly 160 over 100 or 110. For the next 24 to 48 hours, cautiously normalize blood pressure back toward baseline. There are 3 major clinical scenarios where you throw out the 25% rule. Memorize these 4 rounds. First, in acute aortic dissection. The goal here, reduced blood pressure, systolic blood pressure, to less than 120 within 20 minutes, and heart rate to less than 60 beats per minute. Golden rule, always give IV beta blockers before vasodilators to prevent reflex tachycardia, which increases aortic shear stress. In acute ischemic stroke, we have 2 scenarios. Thrombolytic candidates, we must lower blood pressure to less than 185 over 110 millimeters of mercury prior to using tenecteplase, and keep below 180 over 105 millimeter of mercury for 24 hours. For non-thrombolytic candidates, don't treat unless blood pressure exceeds 220 over 120 millimeter of mercury. If treating, aim for a conservative 15% reduction over 24 hours to protect the ischemic penumbra. And in severe preeclampsia, the goal is rapidly reduce systolic blood pressure to less than 140 millimeter of mercury within the first hour. And here we administer IV magnesium sulfate for seizures, prophylaxis, and plan for delivery. Now let's break down the IV medications you will actually be titrating at the bedside. First, we have Labetalol, which is combined alpha and non-selective beta blocker, which has fast onset but long duration, which is a great choice for lowering systemic vascular resistance while keeping heart rate stable. But avoid in decompensated heart failure, severe bradycardia, or acute asthma or COPD exacerbations. The second choice is Esmolol, which is ultra-short-acting cardioselective beta antagonist with 9 minutes as half-life. Esmolol is the go-to agent for heart rate control in acute aortic dissection and easily titratable and quick to turn off if hypotension occurs. Nicardipine is a potent arterial vasodilator, predictable and great in neurocritical care, but requires a high fluid volume carrier. Clevidipine is ultra-short-acting lipid emulsion, and it is contraindicated in soy or egg allergies. Nitroglycerin is a venodilator at low doses and arterial vasodilator at high doses, best used for hypertensive cases with ACS or acute pulmonary edema. And it's absolute contraindication if the patient used sildenafil within 24 to 48 hours. Finally, we have sodium nitroprusside, which is direct arterial and venous vasodilator, but its use has significantly dropped due to risks of cyanide toxicity and coronary stall syndrome. Now I will give you some practical advices. First, always use an arterial line because cuff pressures can lag or give false spikes during rapid IV titrations. Second, check volume status first. Severe hypertension causes pressure natriuresis, leaving many patients volume depleted. Avoid routine loop diuretics like furosemide unless the patient has clear pulmonary edema. Finally, plan the oral transition. Once organ stability and safe blood pressure targets are held for 12 to 24 hours, start oral agents and taper the IV infusion gradually to prevent rebound hypertension. That is your clinical blueprint for mastering severe hypertension and hypertensive emergencies. Remember, check for target organ damage first. Don't over-treat asymptomatic patients. Know your 3 exceptions and pick the right IV drug for the organ affected. If you found this video valuable, hit like, leave a comment below with any questions, and share this with your clinical team. Until next time, keep optimizing care, stay safe, and I will see you in the next breakdown.